the settings for everybody to be admitted.
Really?
Okay, so just as they come through, will you just say to them, we've already started recording? Is that okay?
Yeah, one by one, like.
Well, no, not one by one, just before you yeah. Before you start, or just remind them a couple of times. Because
Hopefully
they're a shy bunch, shall I say?
Yeah, yeah. Did you get your issue sorted?
I'm gonna run up there now to meet them.
Never a dull moment, is there, Claire?
Honest to God, honestly. Right, I'll be back as soon as I can.
All right, well,
All right,
thanks a million.
thank you. See you in a bit.
See you in a bit. Hey, Sophie.
Hi, Joe. You okay?
You're the first one on so far. Oh, I've got my camera blocked. The first one on.
Oh well, I thought I'd get on a bit early before I forget.
Yeah. It's been recorded already. So Claire's had a bit of an issue with a student, so she's had to go off and sort it. So we're being recorded already. So it's just I need to remind everyone that logs in.
Yeah, don't swear or anything like that.
Exactly.
Oh, you okay?
Yeah, not bad yourself.
Yeah, not too bad. Just got a few people this morning, and then it's a bit busy this afternoon. Glad I blocked it out.
Yeah. It's always busy, isn't it? Are you doing the optimization clinics or
Yeah,
something?
yes,
Yeah.
optimization today, and then I've got the field poverty clinic on Thursday.
Mhm.
Only got a couple face-to-faces, so it's not too bad.
Are you finding phlebotomy in the community any better? I'm having an absolute nightmare with it at the moment.
In what way?
Just getting the bloods actually taken and getting the results back.
It's getting the results back is a bit hit and miss depending on the way that you fill out the form. So
Okay.
a lot of the time, like if you take like full blood count and then you want some like an IgE RAS or some kind of other like department, they'll do the full blood count and then like bin it. So it'll
Okay.
never get to the other parts of the lab.
Yeah.
So
It's
I'm
not
having to
ideal.
print off like loads of forms
Yeah.
so that they get to the right place.
So you're doing them all separate, are you?
Yeah, more or less. Unless it's like I do like one biochem one for hematology, and then one immunology one. But it gets a bit of a nightmare when you're trying to do like a broad range of bloods.
Yeah.
And then I'll always just say book in now, and then by the time you get your appointment, hopefully your form will have arrived in the post.
Yeah.
Because the
I've had that a
appointments
few
are long.
times. They said they haven't had the form in the post.
Yeah.
Mm.
Hopefully if we can sort out ICE on EMIS, it should be a bit easier.
Yeah. Yeah. It's a lot easier. When I go to the GSF meetings, the GPs were showing me how they order bloods and scans and things, and it's so easy. It's
It's all
literally
online.
click, all done. Don't have to worry about it.
Yeah. Well, we were like I don't know, 5-10 years behind electronic prescription, so God
Right.
help us with that.
Oh dear. I think I'm having to admit each person one by one, so this is going to be interesting. Is that popping up on your screen, Soph?
I can hear the buzzer, but I can't.
Okay.
I don't think I can admit people.
Yeah. I'm having to admit people one by one, so or maybe as Claire said, sometimes people come in a little bit late, so I'll maybe just delay the session a little bit because it'll be distracting if people are wanting to be admitted when I've started, if you know what I mean.
Yeah, I remember when we did the PA teaching back in February, I think it was.
Yeah.
And there was like 80 people at one point joining. And so
Right.
all I could hear was doot, 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 doot. And I was like,
Yeah. It's a bit off-putting, isn't it?
yeah, so I'd be like, Nana, can you admit people while I'm talking? Yeah. I'm gonna pop to the loo just a sec while everyone joins on.
Yeah. See you in a bit.
Morning.
Hello, Jamie. Okay, you're the only
Yeah.
face I can see so far.
Yeah. I think I'm working from home today, so I think everyone will be slowly joining from the team.
Real. I'm on my own at the moment. Our kind of education lead has had to go and sort a bit of an emergency, so I'm just gonna maybe wait a few minutes because I'm having to admit each person one by one, so it'll be a bit off-putting if I've started the presentation and I have to keep admitting people. So we'll maybe wait till about 5 past and then get cracking. Morning, Drew.
Morning.
You okay?
Yeah, I think I'm getting a cold, so I'm feeling a bit ugh.
Yeah, I've got the man flu myself, so you'll have to bear with me at times. I think I'll try and mute if I have a cough attack.
At least I can sympathise for you.
It's been recorded already, so Claire's had to go and sort a bit of an issue, so I'm just reminding people as they come through. So still having people coming through. I think we've got 7 at the moment. We've still got people coming through, guys, so I'm just gonna delay a couple more minutes just to give people a chance to log on. Sorry about this delay. Some notes. Can everyone see the slides? Okay,
Yeah.
brilliant. Real. Oh. I think people have stopped coming in now, so we'll probably make a start, if that's okay. So my name is Joe Donohoe. I'm the palliative care lead for the Knowsley Community Respiratory Services team. And I've also got a background in specialist palliative care. So hopefully I'll be able to bring the best of both worlds to this discussion regarding palliative care and advanced respiratory pathology. So maybe ask questions in the chat or at the end, and we'll try and answer all your questions if we can. As I've said before, I've got a dose of the man flu at the moment, so you might have to bear with me at times, but hopefully we'll get through okay. So what we're going to cover today, we're going to look at basically every aspect of palliative care. So kind of overview of all the kind of main aspects within palliative care in relation to advanced respiratory conditions, how we manage the symptom control element of it. We're going to explore prognostication and disease trajectories. And then we're going to have a little look at advanced care planning, because it's a massive part of what we do on a day-to-day basis. And obviously elements of that will be capacity and shared decision making. And then we're going to look at core principles towards end-of-life care as well. So a real overview of palliative care in advanced respiratory conditions. So what is palliative care? So I would encourage you to think of palliative care as more of a philosophy of care in comparison to, say, a model of care, like a medical model or a rehabilitation model. It's what we do and how we do it. It's more of a philosophy of care. So what it is, it's very patient and family centered. So the patient and the family are at the heart of every decision we make within palliative care. So really, really patient centered. It needs to be a holistic approach. So whether it's holistic assessments or holistic interventions we're providing. So we're looking to cater for the physical, psychosocial, spiritual and religious needs of that person and their family around them. We want to provide excellent and timely symptom control. And obviously advanced care planning is a massive part of what we do on a day-to-day basis, especially when patients decide they want to be at home for their end-of-life care. So if you're looking for a little bit of extra reading, you can look up the WHO Guidelines 2020 or the NICE Palliative Care Guidelines, just for some extra kind of depth, really. So COPD. So I picked COPD. I'm not going to spend too much time on the kind of background COPD, because I know you've done talks already, but it was really just to demonstrate that it is a palliative condition. So you've got that irreparable lung damage, your mucus hypersecretion, that classic lung obstruction, and that chronic inflammation, really. And if you look at the literature surrounding COPD, it's actually a palliative condition from diagnosis. So if you think about what we do in a diagnostic clinic, we diagnose patients based on their spirometry and their symptoms, and we give them an inhaler. And unfortunately, that inhaler doesn't cure the COPD, but it just manages the symptoms of the COPD. And those symptoms get progressively more complex the further we go into the disease trajectory. So this is just a slide on the actual costings of COPD for the economy and the healthcare service. So I need to thank one of our consultants, Emma, for this slide. So I borrowed it from her. So thank you, Emma. But it really blew my mind the first time I seen it, how expensive COPD is as a whole. So we know we've got about 1.2 million patients with a known diagnosis of COPD, and we've got hundreds of thousands more patients walking around who have COPD but don't know it and are undiagnosed. Direct cost to the NHS yearly is 800 million. And bear in mind, these figures are from 2021, so inflation on top of that as well. It's responsible for 30,000 deaths a year, 82 deaths per day, and it's the second most cause of emergency hospital admission. looking at the economy as a whole, it's responsible for 24 million lost working days per year at a cost of 3.8 billion per year in lost productivity. So mind-blowing figures, really. It's a very, very costly condition on its own for the healthcare service and the economy. So moving on then to our disease trajectories. So gone are the days where we would have a patient in front of us with just one condition. So they'll have multiple comorbidities. 99% of the patients I see will have multiple comorbidities. They may have multiple respiratory conditions. They may be frail, elderly, have other conditions such as dementia, Alzheimer's, or they may have a malignancy on top of that as well. So I think it's really important that we have an understanding of all the main disease trajectories, really. So if we can draw your attention to the first one in black. So obviously you've got your functional level on the left-hand side, low to high, and then you've got your prognosis on the bottom scale. So the first one we're going to look at is the cancer disease trajectory. So it starts off really high functional level, and that maintains itself, so it stays stable, really. And then there is a point where there is a noticeable massive decline, really, in the patient's functional level towards end-of-life care. It's a one-way slope. Unfortunately, these patients never recover to baseline. The second line there, the red line, is your organ failure disease trajectory. So that will cover all your cardiac conditions, all your respiratory conditions, and things such as liver failure and renal failure. And you can see it's a classic relapse-remitting pathway. And these troughs could be an exacerbation of their condition, a hospital admission, a pneumonia, anything like that. The patient's never quite getting back to their baseline. The pointer's disappeared. Where is it gone? So they're never quite getting back to their baseline, and they continue to deteriorate towards end-of-life care again. And the next disease trajectory is your frailty disease trajectory. Again, it's a relapse-remitting pathway, but you can see sometimes the patients do get back to their baseline and above their baseline, but they do have a really low functional level all the way through. And if I can bring your attention to this area here of all of the disease trajectories, this is your approaching end-of-life care. So this is approaching your last year of life, where we know that healthcare utilization goes through the roof, really. So it increases rapidly. So if you think of exacerbations of all these disease trajectories, hospital admissions, GP appointments, community team appointments. So, hospital or healthcare utilization really escalates in this part of all the disease trajectories. So moving on to prognostication. So I've concentrated really on the respiratory conditions here for this one. Prognostication. So the gold standard frameworks is built into all our processes and procedures in Knowsley and St. Helens. So we follow the GSF protocol. So with prognostication within GSF, it's a 3-step process. I think it's important to highlight really that within COPD, there's no recommended prognostic tool in our latest NICE guidelines, but we do use GSF in Knowsley and St. Helens. So we kind of stick to GSF. First step is the surprise question. Would you be surprised if the patient in front of you was to die in the next 12 months? And if the answer is no, you would then move on to step 2. So it's quite basic. Sometimes your gut feeling is kind of most important of all of these, really. So you've moved on to step 2, which are your general indicators of decline. Is this patient continuing to decline in spite of optimal interventions, optimal treatments? Is their functional level continuing to decline? Are they in a chair or are they in bed for more than 50% of the day? Is their disease unstable? Are they getting lots and lots of exacerbations or lots and lots of unplanned hospital admissions? And then moving on to some more medical ones. Is their appetite decreasing? Are they losing weight continuously? Are they having falls? Is their serum albumin below 25? So obviously they're not going to absorb their medication optimally. And could we consider them eligible for a DS 1500 payment? So all of these are general indicators of decline. So generally what we say, if the patient in front of you has 3 or more of these indicators, we would move on to step 3. So step 3, again, I've stuck with the respiratory specific indicators here. But if you do want more information about the other disease trajectories, just go onto the Gold Standard Framework's website and it breaks them down into disease specific prognostic indicators for you. So with the respiratory ones, if the patient's got very severe COPD, if they're on long-term oxygen or they meet long-term oxygen criteria and we can't give them oxygen because they still smoke, if they've had 3 or more hospital admissions or exacerbations in the last year, if they're on non-invasive ventilation or they've had an admission to critical care, if they continue to smoke, so obviously they're ruling themselves out of oxygen, they're ruling themselves out of, say, azithromycin treatment with long-term antibiotics because there's no evidence to support that it works in smokers. We're quite concerned about them if they've got a low BMI, so BMI under 20. So if you think about when they have an exacerbation or if they pick up a pneumonia or something like that, they don't have the reserves there to fight these off. If they've had more than 6 weeks of steroids in the last 6 months, and if they're showing any signs of right-sided heart failure. So again, all of these are indicators of decline. And what we would say, if they have 3 or more of these indicators, it's highly likely that they're approaching the last year of life. So it's just to bear those in mind, really. Moving on. So we're moving on towards our advanced care planning part of the session. And obviously capacity is a massive part. It's a fundamental basis of everything we do on a day-to-day basis, whether you're doing it formally or informally or subconsciously even. We do these capacity tests all the time. So I'm going to give you the short story here, capacity. If you want the long story, go and read the Mental Capacity Act. But these are your 4 main principles. So we need to assume the person's got capacity until we can prove otherwise. Again, very basic, very simple, but it's very important. Capacity is decision specific. So we're doing capacity assessments for one specific decision at a time. So there's no such thing as blanket capacity or blanket no capacity. It's for one specific decision at a time. And a patient may be able to make a decision about one specific decision, but may not be able to make a decision about another specific decision. So that's a really important aspect. The next one is it's time specific. So a patient may lack capacity in the morning, but if you reverse the reversible or treat an exacerbation, or if you reverse hypoxemia, they may have capacity in the afternoon or the next day or the following week. So it's time specific as well. And if we've deemed that a person has capacity, we need to respect that patients can make unwise decisions. So you'll all have been with a patient, they need a hospital admission, they may have severe hypoxemia, but they're refusing to go to hospital. You've given them all the information, you've outlined the risks involved of not going to hospital, and they still want to stay at home. So we have to respect that they can make an unwise decision as well. So there are your key components of capacity. Moving on to mental capacity testing. So there's only one formal way of doing a mental capacity test, and it's a 2-stage test. So stage 1, does the patient in front of you present with an impairment of the mind or the brain? So I'd encourage you to think acute versus chronic causes. Are they having an exacerbation? Are they chronically hypoxemic? Is there something there that we can reverse? Versus your chronic causes, have they got a diagnosis of dementia or Alzheimer's or some condition like that? If the answer is yes, you would then move on to stage 2. You would then discuss the decision that they're attempting to make at that time, give them all the pertinent information at the relevant level. can the person weigh up the risks involved? Can they retain that information long enough to relay the information back to you and actually make that decision? So that's a capacity assessment in a nutshell. So as I said, we do these formally, informally, subconsciously all the time. And it's the only way of actually performing a mental capacity test. So it's for one specific decision at a time. It's time specific as well. So you may have to do multiple capacity assessments to actually do the assessment thoroughly. You can use cognitive tests as well as an adjunct, but you know, things like mini mentals, they're not the actual capacity assessment, they're just an adjunct to the actual two-stage assessment, if that makes sense. So what I'm going to do is just going to share a video here with you regarding capacity. Hopefully this works for me. Apologies for any ads that pop up here on YouTube. Can everyone see the screen okay?
I can't hear it though, Joe.
Can't hear it. Let's go back. Not any better?
No, I still can't hear it.
I don't know how we can. Not sure because I've got the volume up on my device and on the actual video as well.
Is it the way that you're sharing your screen? Maybe.
Yes, so I'm just sharing the screen. If we share it in a window, may it be better?
Maybe.
I'll have to come right out though. Let's have a look. Stop sharing.
If not, we can always, if you put it in the chat, we can always look at it like later
Yeah.
or something.
Brilliant. I'm just gonna play it here once more just to see if it works for you. Any sound?
No, not
No.
for me.
Not to worry.
Joe, I was just going to ask, you know, when you said about the retaining the information,
Yeah.
is that like immediate? How long would you sort of wait to see if they've retained it? Because obviously, I can imagine some people it would be that they'd be able to retain it for a little bit, but maybe not as long as others.
Yeah. So it's just they need to retain the information as long as it takes them to communicate their decision back to you. So it could just be the length of that conversation. So
Lovely, thanks.
you know, once they've kind of verbalized that decision to you and they understand all the risks involved, that's your capacity assessment completed. Then they may have forgotten the conversation 10, 15 minutes later, but they've actually, in that moment, they've passed your capacity assessment. Does that make sense?
Yeah.
Yeah.
Thanks.
Can you guys see my slides again?
No, I've got the video, YouTube video up.
Bear with me. They're back.
Yeah.
Thanks, Alf. All right, moving on. So obviously, if you've done your capacity assessment and your patient lacks capacity, we then need to look at best interests and treating that patient in their best interests. So this best interest wheel should help you make that best interest decision. So bear in mind, it could be anything from a change of inhaler or a change of medication, to refusing a hospital admission right up to where the safest person is, the safest place for that person to be cared for is. So for something as big as that, you may need a formal best interest assessor, which we would access through the social work service. So in Knowsley, there's a best interest assessor allocated every day. So for big decisions like that, you would need to obviously contact them and get them involved in it. So looking at this best interest wheel then, so obviously we're wanting to apply the least restrictive option on that patient's day-to-day living, day-to-day life. So the most least restrictive option is what we're trying to put into play. So to get that least restrictive option, we would obviously include the patient in that discussion. We would also include their family or any carers or any nursing staff if they're in a nursing home, or if they're on a ward at the moment. We'd include all of those people in the decision. We would also want to include any other healthcare professionals involved in their care. So whether it's their GP, if they have a matron or a district nurse team involved, we would include them as well. Or for our patients who would maybe have addiction issues, we would include the CGL team or any kind of care worker that they had involved in their care. Obviously, we would want to avoid discrimination against any category of at-risk individual, so that goes without saying. And we do need to bear in mind that this person can regain capacity anytime, so you may have to do multiple capacity assessments. And hopefully, if we follow this best interest wheel properly, we've come to the least restrictive decision made in that person's best interests. So it's just to bear in mind if you do see a patient that lacks capacity, just to try and use these key components really of best interests if you do find yourself in that situation. Obviously, if you're unsure, get a more senior person involved or get a best interest assessor involved, and they can help you with that. Moving on to advanced care planning. So obviously, advanced care planning is a massive part of what we do on a day-to-day basis. But what is advanced care planning? So it's an ongoing process. So if a patient wants to make an advanced care planning decision, or they've chosen to write an advanced care planning decision down, we need to make sure we give the patient the opportunity to review this process at any time. And obviously the patient can change their mind at any time. We review the situation and we start again. It has to be a voluntary process as well. So we can't coerce or force patients into making these advanced care plans. So they need to do it on a voluntary basis. And a lot of the time we find it's like planting seeds. This is what's available. We're looking to protect what's important to you now and in the future. If they have any kind of key wishes or key goals or key aspirations regarding future care, it's just letting them know what's available. So we do have informal or formal documents to help support you with your future care preferences. So it's about what's important to them now and in the future. Specifically, if they have any specific treatments that they don't want, or they have any specific wishes that they do want. So if they want to be at home for their end of life care, or quite a lot of the time I've got patients that will want to refuse specific treatments in advance. It tends to be non-invasive ventilation. So depending on what they're telling you, what their beliefs, their goals, their values are, we have different documents to support those decisions. And it's just to ensure that they receive care in future that matches with their wants and needs, really. And again, mental capacity is a massive part of advanced care planning. So firstly, the patient needs to have mental capacity to complete an advanced care plan. And secondly, advanced care plans only kick in once the patient has lost capacity to make a decision. So they're only relevant once the patient loses mental capacity. That's when they then become active, and that's where they kick in. So it's just to make you aware of that, really. So as long as the patient can tell us what they want and what they don't want, it's absolutely fine. But the advanced care plans only kick in if they lose capacity. So there's 6 core principles of advanced care planning, and I'm not going to read off the slides. What I've done is I've picked out the specific important words in each sentence. So ACP needs to be central and personalised. So it goes without saying the person is at the centre of that decision. They get to choose who's involved in making that decision, whether they want their family involved or not, whether they want their carers involved or not. So it's very patient-centred. Again, it's very specific to that individual. So there's no one advanced care plan suits every single patient. So it's very, very personalised and individual. So it depends on what that person wants and what they don't want. The person needs to agree to an advanced care plan, goes without saying. They also need to agree on what is documented on an advanced care plan as well. So they need to agree to every single little thing that we've written down on their advanced care plan. The advanced care plans need to be shareable. So we need to be able to share these advanced care plans with other healthcare professionals involved in their care. And obviously we need to get consent to do this. So we would be having those discussions before we've sat down to complete an advanced care plan. It's particularly important that we share the advanced care plans with out of hours teams as well. So essentially what we're trying to do is prevent an out of hours crisis or any unnecessary hospital admissions. Opportunity. So the patient needs to have an opportunity to complete an advanced care plan, but they need to be given opportunities to change their mind regarding anything they've written down in the advanced care plan. So we need to offer this at key junctions really, or at least on a regular basis. And speak up is the last one. So for the patient, the family, carers, anyone that's been involved in making that advanced care plan, if they feel it's not been done in an appropriate way, using these 6 core principles, they have the opportunity to speak up and verbalise that. And then what we would do then is tear up the advanced care plan and start again. So we need to make sure everyone's happy with the advanced care plan that we've completed. So again, they're all quite simple, quite straightforward, quite basic principles, but they're really, really important. And if these 6 principles aren't upheld when we complete an advanced care plan, it's not valid. So hopefully that makes sense. I did have a video on advanced care planning, but it's probably not going to play like the capacity one. But I will pop the links in the chat, or you can contact Claire maybe afterwards, and then we can send out the links to the videos. Sorry about that, guys. And just to summarize advanced care planning really. So we're obviously letting the patients know that advanced care planning is available. We're getting them to think about what's important to them now, what's important to them in the future. I would always encourage them to go and have a discussion with your family, with your carers, and I'll maybe come back and see you next week or in 2 weeks. Just give them as much time as they need. And then if they're obviously willing to complete an advanced care plan, they can do it orally or formally, they can write it down. There's different levels of advanced care plan, from informal to legally binding, which I'm going to talk you through in the next few slides. But we obviously have to share, if they've completed advanced care plan, we have to share that with other professionals. So we do need to make the patient aware of that. And it's just to protect their wishes moving forward. It's a voluntary process. Capacity is key. With our documents in Knowsley and St. Helens, they're patient-held documents. So once they've completed a document, it will stay with them. And obviously we need to give them the opportunity to review those advanced care plan and documents at regular intervals. So moving on. So this is our Planning Your Future Care document. Very basic, very simple document. It's patient held. It only kicks in once the patient's lost capacity. And a lot of the feedback I've had over the years is, how do we start a conversation? So with this document, it actually tells you what to ask the patient. So the first box there, hopefully you can see it, what's important to me now and in the future. So that's literally what you would say to the patient. And what I will be documenting in this box is very individual to that patient. It could be spiritual beliefs, it could be religious beliefs. I want to see my priest before I die. I want to have the last rites before I die. It could be anything. It could be how they want to be treated in hospital. I want to be washed every day. I want to be dressed in my own clothes if I'm in hospital. It could be dietary requirements. It could be anything. So it's very specific to that patient that's sat in front of you. The second section here is the more kind of medical section. What would you like? What would you want people who might care for you to know about your wishes or preferences? So it's a lot more specific. So in this box, I would be writing things like, I do not wish to be resuscitated. I do not wish to be admitted to hospital. I wish to be cared for at home at the end of my life. To maybe who they want to be around them at the end of their life. So again, more kind of specific treatments. It could be a treatment that they don't want to have in the future, non-invasive ventilation, IV antibiotics, anything really. So that's the more medical section. Section 3 then, it just gives the patient an opportunity to address any wish or any concerns they have now and in the future. So it's just opening that conversation. Are you stressed about anything? Are you anxious about anything? Any concerns now? Any concerns in the future? So it does what it says on the tin. Basically gives you the conversation openers as well. I would be looking for cues from the patients as well. So kind of verbal cues, non-verbal cues, body language. If they've had a recent exacerbation, if they've had a recent hospital admission, how did you find that you were treated in hospital? A lot of the time it will stem from if they've had a bad experience in hospital. So they're all cues that you would want to run with really. Tell me a bit more about that. How would you want to be treated in the future? Are there any treatments you had in hospital that you wouldn't want to have in the future? So that's kind of how I would approach it really. So that's your most basic one. So it's a non-legally binding document. Moving on to our advanced decision to refuse treatment. So this is if the patient has any specific medical treatments that they don't want to have in future. I would be thinking about completing one of these documents with them. So it's a legally binding document. Once it's done correctly and appropriately, it cannot be overruled. Again, capacity is key with this document. So I would be doing a capacity assessment for each specific decision or each specific treatment that they want to refuse in the future. You do need to have a witness in the room when you're completing this document. So whether it's the patient's family members or carers, just make sure you have a witness, and the witness actually has to sign off this document as well. So if I was going to complete an ADRT with a patient, I would obviously have that appointment pre-booked in advance, and obviously make sure that the witness is able to attend. Generally, I complete maybe a dozen of these a year. It tends to be to refuse non-invasive ventilation. I've done one recently where a patient wanted to refuse artificial feeding in the future, and it really got me thinking about my own preferences and wishes about the future. I definitely don't think I'd want to receive artificial feeding moving forward. And I've had to complete some of these when the patient wants to refuse resuscitation in an emergency situation. So obviously I'm not a doctor. I'm a physio by background, so we cannot complete LILAC forms at the moment in our area. But if you do have to, if the patient doesn't want resuscitation and you need to complete that in an emergency situation, this is your kind of way around it by completing an advanced decision to refuse treatment. So I've had to do a few of those in the past. So moving on to our lilac forms. I don't know if that's coming up as lilac on your screen, but it'll be like a purpley lilac colour. Again, as an AHP, we're professionally bound by this document being there or not being there. So if the document is there with a patient, professionally, I wouldn't be attempting resuscitation if they had a cardiorespiratory arrest. Again, if it's not there, we're professionally bound to start resuscitation. Quite often this document, more than the other ones, can be a source of stress and anxiety and a lot of upset, really. And I find in my experience it can be down to how the initial conversations had. And a lot of the times that can happen in hospital, whether the patients maybe not felt very well at the time, or they've not got family support with them at the time, or how the conversations had. Quite a lot of the time it's not explained to the patient that this is only valid for a cardiorespiratory arrest and it does not rule out any other active interventions. So quite often they're not aware of that. And when you sit them down and have the conversation about resuscitation, quite often they will come around then. With our lilac form across its boundaries, so it's accepted throughout the Northwest. It's really important if you've got a patient in the community that they bring all of these documents in an ambulance with them or into hospital with them. Otherwise, they don't exist, unfortunately. So that tends to be where the ACP documents fall down, really. So that's our lilac form. Again, just, I don't know if you can see the document too clearly, but kind of key areas to check these documents obviously is that all of the pertinent information is on here. So the date, the decision, the institution name, you've got consent, the doctor obviously needs to put their GMC number on here. I would always just check that the reason for the DNA CPR decision has been completed properly. And then again, moving on down, there's a review date on here. So if the review date is blank, that's absolutely fine. But if they specify the review date and you've gone past that review date, the document is no longer relevant. So I would be calling a GP or writing to a GP to get them to review the decision and, you know, put a new lilac form in place. So they're kind of our main areas that I would look out for on that form. Skip that. So moving on then to our symptom control part of the discussion. So the main symptom control issue that I see on a day-to-day basis is dyspnea or anxiety related to dyspnea. So it's a really, really complex symptom control issue. The reason there's lots of definition of dyspnea on here is that there's not one definition fits dyspnea. So it's a very unpleasant sensation. So I haven't met one patient yet that has enjoyed being breathless. It's a multi-dimensional experience. So it's got physical, psychological, psychosocial really, and behavioral aspects attached to it. It's subjective and very individual. So it changes based on the patient in front of you. So it's different from patient to patient. It can be related to our oxygen transport, especially if the patient in front of you is hypoxemic. You know, they're going to be breathless as well, but it's not always the case. And we can have dyspnea at rest, on exertion, or in the terminal phase. So I presume that everyone is seeing that in our day-to-day practice. Hopefully it makes a bit more sense. So this is our dyspnea cycle. Hopefully you can see that on the screen. So we've got our breathlessness in the center. And as I mentioned before, we've got our physical, psychosocial, and behavioral aspects to it as well. So if we start at the breathing, so the patient may present with a high respiratory rate, not always. They may have an inefficient breathing pattern. They may be apically breathing. Their posture may be not optimal. So our patients tend to have like a lean forward posture. They'll tend to fix through their shoulders. They'll tend to fix through their chest wall. Moving on to the thinking aspects then. So 99% of the patients you see who are breathless will have some level of anxiety related to it. They may have panic attacks, they may be distressed or have some psychological distress attached to their breathlessness. And some patients will actually say they feel like they're dying when they have an anxiety attack. So very, very severe anxiety. Moving on then to the functioning part of it. So what I found over the years is patients will quite quickly learn to avoid things that cause them breathlessness. So they'll stop moving, they'll stop mobilizing, they'll become less active, they'll stop doing things like going on the stairs, they'll stop going out socializing, they'll stop going to see their families in their own homes. So this obviously leads to reduced exercise tolerance, reduced mobility. They're more likely to have falls, and it can lead to social isolation as well. So again, it's just being aware of all these aspects of breathlessness. It's very, very complicated. And then it's just adding in your interventions depending on the patient you see in front of you. So it's tailoring your interventions to that patient in front of you. So there's a selection of interventions here. Hopefully you can see all those things, but I'm going to go into them in more depth in the next couple of slides. So moving on. So non-pharmacological management measures. So obviously I'm a physio by background. So we would implement a lot of these things for patients who are breathless. So breathlessness management, whether that's a one-to-one session or a group session. The same would apply for anxiety management. So looking at strategies to help with their breathlessness or their anxiety. We have pulmonary rehabilitation. So whether that's in a group setting or one-to-one at home. So you're looking to implement the exercise and the educational components in pulmonary rehab to help the patient self-manage their breathlessness. If the patient's breathlessness stems from an issue with chest clearance, we can implement chest clearance. So whether it's your kind of basic active cycle of breathing, your huffing, your forced expiratory techniques, or moving on then to the more complex PEP therapies or your oscillating PEP therapies to help them clear their chest. So things like our aerobica or our flutter devices. So we can use that to help them clear their chest, and hopefully that will help with their breathlessness as well. Sometimes stress about the future can be a cause of breathlessness. So sometimes completing advanced care planning can help the patients get that weight off their chest. And once they've done the advanced care planning, sometimes their breathlessness and their anxiety levels can reduce. We also use fans a lot of the time, really. So quite a simple but effective intervention. So the movement of cold air across the patient's face will stimulate their trigeminal nerve, which will reduce their breathlessness. And sometimes patients have actually figured this out themselves, so they'll be sat by an open window or an open door, and it's what they're wanting is the movement of air across their face. It's really effective. We can also look at their postures and find positions of ease, and posture re-education. Later on down the line, we can add in aids and adaptation. So whether that's things like walking aids, stair lifts, and they can all help the patient actively adapt to their breathlessness and their kind of deteriorating condition, really. In Knowsley, we have access to psychological support services. So we have a psychology service that we can refer into once the patient's breathlessness or anxiety is impacting on their daily activities. They tend to accept the referrals. And moving on towards kind of end of life stages, it becomes an integrated approach in the community. And as I mentioned before, the GSF is kind of embedded in everything we do towards end of life or that last year of life in Knowsley in particular. And I'm going to cover that later on down the line. So pharmacological management. So my little catchphrase is reverse the reversible and manage the irreversible. Is there anything in that patient in front of you that we can reverse? Are they hypoxemic? Do they need treatment for an acute exacerbation? have we optimized their inhaled therapies? Have we optimized their nebulized therapies? If they've had 3 or more infections in the last year, are they suitable for long-term antibiotics? Smoking cessation is obviously key. If the patient continues to smoke, it's obviously directly linked to their life expectancy. If they manage to give up smoking, we can extend their life, and then they're obviously suitable for treatments such as oxygen at home or long-term antibiotics. Once the patient's breathlessness or anxiety is refractory in nature, we can then start to introduce our symptom control medications. And then towards kind of last weeks to days of life, we will obviously have just in case medications in place at home, particularly for the patients that want to have their end of life care at home. We'll have subcut medications and medications to go into a continuous infusion at home in the patient's property. So, symptom control for refractory breathlessness. So I'm going to talk you through the safest way of initiating and titrating symptom control with patients with refractory breathlessness. So once they're optimized on all their other disease modification treatments, we can then start to consider symptom control measures. So there's some things that I would like to be aware of before I initiate symptom control. So is the patient opiate naive? Have they had opiates in the past? Have they had any adverse reactions in the past? You would also want to know their BMI. Is this patient going to be able to absorb the symptom control medications effectively? Their renal function is quite important as well. So if they're approaching an EGFR of 30 or their EGFR is less than 30, it's going to change your first line opiate from morphine to oxycodone. And you also want to know if the person's got a history of drug or alcohol abuse. If they do, it really complicates things a lot. And you would want to be bringing in the multidisciplinary team then for these type of patients, or if they have a CGL counselor, or obviously their GP as well. So those are the things I would want to be aware of before I'd initiate symptom control. As I mentioned before, our first line would be morphine. So I tend to start low and go slow. So we could look to initiate the patient on 1.25 mils of morphine up to QDS. If they have any of these four things involved, I would generally give them a half a dose. So I'd start them on 1.25 mils BD. You can always titrate as you need. So patients obviously need regular reviews. Once you get the patients up to 10 milligrams a day, we can start to consider our 12-hour modified release tablets. They tend to help with compliance, consistency, and they're really good for giving you nighttime coverage of the symptom control issue. So if you think about an immediate release oral morphine, technically for their fourth dose, they would need to get up in the middle of the night to take that dose, whereas you don't have this issue with the 12-hour modified release tablet. So it's one of the main benefits, really. It goes without saying that all of these decisions are shared decisions. So we're having a chat with the patient, the family. We figured out that the issue was breathlessness or anxiety. These are the options in front of us, A, B, and C. These are the potential side effects or adverse reactions, A, B, and C. Do you need any further information? Do you need written information? Do you want to go online and look up the medications, yourself? And then we move on then to a shared decision. So do you want to proceed with this treatment? Yes or no? Simple as that. Again, very, very basic, but a fundamental core of everything we do on a day-to-day basis. With opiates, you've got a safe ceiling of 30 milligrams in a 24-hour period. So anything from 0 to 30, it does not increase hospital admissions and it does not increase mortality. After 30 milligrams, we don't know. So there's no evidence to show that after 30 milligrams is safe and doesn't increase mortality or hospital admissions or things like falls. We just don't have that evidence base at the moment. So as I mentioned before, your second line would be oxycodone. So if the patient didn't tolerate morphine in the past, or they've got a low eGFR, I would use oxycodone instead. Same principles apply. Start low and titrate slowly. And then you've got obviously lots of 12-hour modified release options with oxycodone. You've got 24-hour preparations as well, but we tend to use the 12-hour modified release tablets. Once we've got them onto, say, maybe a dose of 10 milligrams in 24 hours. If you've optimized their opiate and they still have breathlessness or anxiety, that's when I would add a benzodiazepine in. I tend to keep benzodiazepines back as third line because once you added a benzodiazepine into that patient's care, hospital admissions go up and mortality goes up straight away, even if it's just a 0.5 milligram of lorazepam. They're very, very addictive as well, so you tend to get a snowball effect with benzodiazepines. So their dose will tend to increase quite rapidly, and the patients tend to become very dependent on them. Particularly lorazepam, because it's short acting, the patients tend to seem to get addicted to those quite quickly. There's actually been new recent update to the BNF, and it's recommending that if you've got a frail and elderly person in front of you, that they should only be on a benzo for 4 weeks maximum. So just to consider all of those things before you add in a benzodiazepine. Our first line is lorazepam, and we would usually introduce 0.5 milligrams up to QDS, and then you can go up to a maximum of 4 milligrams in 24 hours. Again, it's a shared decision-making process. So these are the proposed benefits, these are the potential side effects. Do you want to proceed with this medication or intervention? So hopefully that's made symptom control a bit clearer for you. So shared decision making, we've touched on this. So this is part of the NHS long-term plan for individualised care. So shared decision making is a hot topic at the moment. So what we're doing, we're starting the conversation about intervention A, B, or C. These are the proposed benefits of intervention A, B, C. These are the proposed side effects, adverse reactions of intervention A, B, and C. Go and discuss it with your family. Go and have a look online if you want, or here's written information about the proposed intervention. And then once they've had all the information that's relevant to them at the relevant level, we can then move on and make a shared decision, yes or no. So again, really simple, really basic, but a core foundation of what we do on a day-to-day basis, whether it's just changing an inhaler right up to initiating or titrating symptom control, or definitely a big part of advanced care planning decisions. Core principles at end-of-life care. So end-of-life care, bear in mind, is when a patient is approaching the last year of life. So it covers that whole last year period. So we're looking to identify that as early as possible. So using our knowledge of our disease trajectories, our shared disease trajectories, and our prognostic indicators, we're looking to identify that the patient is possibly approaching the last year of life as early as possible. We want to use sensitive communication, unambiguous communication. So communication that words that cannot be misconstrued as something else. You want to use simple language. We want to avoid medical jargon, and we want to avoid abbreviations as well. So the communication needs to be simple, clear. It's about what's important to that patient then, at that time, and in the future. Shared decision making is a massive part of managing a last year of life episode, as is mental capacity. So the patients need to have capacity to agree to interventions and complete interventions. Bear in mind, capacity can fluctuate through that process. So patient may not have capacity one day, the next week or the next month they may have capacity, or they may have capacity at a certain part of the day. and we need to give that person the most opportunity to show that they have capacity to make decisions. So a patient may prefer to be seen in the afternoon, say, for example, with support from their family. We want to definitely offer or introduce advanced care planning, and quite often it's like planting seeds. Advanced care planning is available. We'll support you any way you want to be supported, whether it's giving you the documents or sitting down and completing the documents with you. They're here for you. We're here for you to support you any way you want to be supported. We need to be reviewing our prescribing all the way through. Is our prescribing safe? Is the patient optimized on their disease modification treatments? Are they optimized on their symptom control measures? And then at this stage, we're looking to pull in the integrated MDT. So I work quite closely with GPs, community matrons and district nurses throughout this process, really. So that's our last year of life. And then key considerations in the last days of life. So very, very similar. We want effective, compassionate communication. So again, using simple language that cannot be misconstrued as other things. It needs to be sensitive. Try and avoid medical jargon and medical abbreviations as well. What we do want to be doing is communicating with all the other healthcare professionals involved as well. So that would be the GP, community matrons if the patient has one, and district nurse teams as well. But also key at this stage is out of hours teams. So out of hours teams need to be aware of what's going on in this patient's care, whether they've got a LILAC form, whether they've got an advanced care plan and document, whether they've got just in case medications in place at home, and whether this person's an expected death. The GPs need to see the patients at least 4 weekly. So a telephone call does count these days. If a patient dies and the GP hasn't seen them within that 4 weeks, it's classed as an unexpected death, which leads to kind of poor outcomes for the families as well. It can lead to a lot of kind of complex grief as well later on down the line. So it's really important that we're getting the GP to see these patients every 4 weeks. We want to provide patient-centered, holistic care with the patient and the family at the centre of everything we do. We'll have optimized the symptom control medications, and we'll have just-in-case medications in place at home in case that patient needs a subcut stat of one of these medications. We're looking to avoid any unnecessary hospital admissions and out-of-hours crises. The ACP should be completed by this stage in advance. It doesn't always happen like that. We do get lots of patients where they will call our rapid response service. We'll see them acutely, and in spite of being severely hypoxemic, they will refuse to go into hospital. And these tend to be the cases where we need to really act really quickly to get all of these things in place if they're still refusing to go to hospital and they have the capacity to make that decision. We'll have a LILAC form in place, and we'll have informed out of hours of where we're up to in this patient's care. So hopefully that all makes sense and makes palliative care and end-of-life care a bit clearer. Just put a few references in there for you as well if you want any further reading. Any questions at all? Apologies, the videos didn't work. I have no idea why they didn't work.
Hiya, Joe. Sorry, what I'll do is I'll stop recording. Is that okay? And then people are free to ask questions. If
Thanks,
everyone
Claire.
could, it's okay. If everyone could please pop their